Tetracyclines can be grouped by generations. First-generation tetracycline is the prototype drug, but today it is used less often because resistance is common. Second-generation drugs include doxycycline and minocycline. Doxycycline is well absorbed and longer acting, so it is commonly used in acne, Lyme disease, and respiratory infections. Minocycline also penetrates tissues well and is used in acne and some resistant infections. Third generation, tigecycline, overcomes many older resistance mechanisms and is reserved for complicated skin and intra-abdominal infections. Chloramphenicol is also broad spectrum, but because of serious toxicity, it is mainly reserved for severe infections when safer options are ineffective or unavailable.
Tetracyclines act on the 30S ribosomal subunit. They bind reversibly and block the attachment of amino-acyl transfer RNA to the messenger RNA ribosome complex. Because transfer RNA cannot attach properly, new amino acids cannot be added to the growing peptide chain. Protein synthesis stops, so bacterial growth is inhibited. That is why tetracyclines are called bacteriostatic drugs.
Chloramphenicol acts at a different site. It targets the 50S ribosomal subunit and inhibits peptidyl transferase, the enzyme needed for peptide bond formation between amino acids. This prevents elongation of the peptide chain and blocks protein synthesis. Chloramphenicol is usually bacteriostatic, but against some organisms, such as Haemophilus influenzae, Neisseria meningitidis, and Streptococcus pneumoniae, it can act as a bactericidal drug. Here is the easiest comparison to remember. Tetracyclines block amino-acyl transfer RNA entry at the 30S subunit, while chloramphenicol blocks peptide bond formation at the 50S subunit. Tetracyclines are widely used for atypical organisms, acne, rickettsial infections, and several respiratory infections. Chloramphenicol is kept mainly for severe infections, where alternatives are not suitable. Important adverse effects of tetracyclines must be remembered clearly. These drugs bind calcium in growing bones and teeth, which can cause permanent yellow or brown discoloration, especially in children younger than 8 years. That is why tetracyclines are contraindicated during pregnancy, during breastfeeding, and in young children. They may also cause gastrointestinal upset, such as nausea, vomiting, and diarrhea. Hepatotoxicity is uncommon, but the risk becomes higher with large doses or in patients who already have liver disease. Chloramphenicol has several serious toxicities. The most feared is idiosyncratic aplastic anemia. This is rare, unpredictable, not dose-dependent, and can be fatal. Chloramphenicol can also produce dose-dependent bone marrow suppression, leading to pancytopenia, and this effect is usually reversible after stopping the drug. In neonates, the drug may cause gray baby syndrome because the immature liver cannot metabolize it efficiently, so the drug accumulates and causes abdominal distension, vomiting, gray discoloration, circulatory failure, and collapse. Let us recap. Both tetracyclines and chloramphenicol inhibit bacterial protein synthesis. Tetracyclines act at the 30S ribosomal subunit and commonly cause teeth discoloration, gastrointestinal disturbance, and sometimes liver toxicity. Chloramphenicol acts at the 50S subunit and is limited by bone marrow toxicity, aplastic anemia, and gray baby syndrome. If you remember the subunit and the major adverse effects, you can answer most exam questions on this topic.